Hello, and welcome to the second annual Connected Health Virtual Summit. This is Vanessa Palmer-Desiato, Project Manager at NextGen Healthcare Media and moderator of today's session, How Ambulatory Care Extends Beyond a Doctor's Walls. Now, I'd like to introduce our speakers for today's session, Kimberly Allen, Chief Quality and Innovation Officer at Delaware Valley Community Health, Mohammed Shabli, VP of Solutions Connected Health at NextGen Healthcare, and Cheryl Leibola, VP of Solutions Patient Engagement at NextGen Healthcare. With that, I'd like to invite Cheryl to begin today's presentation.
Thank you, Vanessa. So today you're in the session of how ambulatory care extends beyond the doctor's walls. We're going to talk about telehealth, remote patient monitoring, and interoperability. And as we mentioned, my name's Cheryl Leibola. I'm the VP of Patient Engagement Solutions. I joined NextGen in 2018 to lead strategic initiatives related to patient engagement. I'm joined today by my colleague, Mo Shabli. He is the VP of Solutions focused on connected health. And we are pleased to include Kim Allen from Delaware Valley Community Health. They use our technology to conduct telehealth, provide remote patient monitoring, and communicate beyond their practice walls. And today, she's going to provide her insights related to remote patient monitoring. And we will hear more about her role and her organization when she begins to speak. So you heard a little bit about who we are. So I wanted to talk about NextGen just before we move to the agenda. We are a market-leading provider of integrated healthcare solutions, services, and analytic solutions for the ambulatory market. You see here some of our stats. We are publicly traded. We have a $1 billion market cap. We have about 100,000 providers that we serve. And you see we have employees, about 2,600 across the US and India and other countries. So as we discussed in the title, How Ambulatory Care Extends Beyond the Doctor's Walls, we will review three topics today. Telehealth, patient-centric and practice-centric capabilities to consider for your telehealth virtual care workflow. Remote patient monitoring, RPM, recent insights and learnings from Delaware Valley Community Health, where Kim will share how her RPM program provided more insights, identified medication cost issues, and believe it or not, helped eliminate barriers with their patient population. And we'll move to interoperability with other institutions, enabling physicians to have access to patients' complete medical histories and to further public health. At the end, we'll have time for the Q&A, and then we'll wrap up the discussion. We thought we'd start by sharing with you what we learned from a recent study that we commissioned with Intelligent Healthcare Media. In this national study, we surveyed ambulatory providers and administrators to better understand their perspective regarding IT adoption and best practices. Some of what we learned, we are showing here. Digital technology adoption boosts patient engagement, and that patient engagement solutions enable financial success and patient access. What is key is that 95% believe provider adoption is critical for success. So that kind of makes sense. If you're going to have patient engagement, you need to also have the providers engaged. What helps with provider adoption? Well, the HIT solution needs to be integrated into the existing technology systems to be optimized. That's that 58% stat. Provider burden is eased with the right solution and increased training, which is 51%. And that successful patient engagement solution also eased provider burden. So if you think about it as a circle, if patients are engaged, that can alleviate the provider burden. And if providers are engaged, that leads to patient engagement and success. Two of the most important capabilities in a patient engagement solution were pre-visit check-in workflows and telehealth. So those are the 76 and 68%. So with that, now we will turn to our poll. Since we mentioned telehealth was one of the key solutions, we'd like to hear from you. What % of care do you believe will remain virtual? About the same % as during the pandemic, 45%. The % of virtual visits will drop slightly, 33%. The % of virtual visits will drop significantly, 15% or less, or 0. We're going to go back to how it was before virtual care. And so Vanessa, any instructions for the poll?
Yes, please fill out the choice that best aligns with what you believe and then press submit. We can follow along on our end back here and see how many attendees have submitted their response. And then once you're ready, Cheryl, you can flip to the next slide to see the live results.
Great, thank you. We'll give it another 30 seconds or so. Looks like we have 64%, actually almost 66 have submitted their results. So I'm going to click over. And the majority of those who have submitted, it looks about 58%, will drop slightly to about a third. That's and no one checked 0, which is good to see. And some still think, about a third think it'll still be about the same as during the pandemic. So about a third of the care or more. What's interesting about that is, that falls quite in line with what McKinsey estimated as what is even available from an office visit in an outpatient care setting. They estimated that about a third, or 33%, of healthcare office visits could be delivered virtually, and 20% of all emergency room visits could be avoided via virtual urgent care offering. More than 8 out of 10 healthcare executives believe telehealth is vital to their organization. So this demonstrates the importance of integrating telehealth into the ambulatory provider's workflow, because if this is going to be such a large volume, it needs to flow with the existing in-office workflow and expand the patient experience, so for both. All right, so that brings us to our first topic, telehealth patient and practice-centric workflows. One more study, just as we talk about workflows, class interviewed clients of telehealth vendors to determine which are viable go-forward options and which deliver the patient experience. And this was along the lines of, if this is here to stay, which you see they tested that theory with their population, their client population, and they fall in line with what the audience thought, 11 to 35%. What really became clear is what about the ease of use and how does it work for patients and how does it work for clinicians. And you do see that NextGen is up there in the upper right-hand corner that we were highlighted as one of those that has both an ease of patient use and but also a very good experience. So what are some of the patient workflows to consider? So telehealth features that further engage patients. Online scheduling is key. Now, you may not think that that's part of telehealth, but the ability to schedule an in-person visit or a virtual visit using the same solution and with that practice is key for engagement. Not all visits are appropriate for virtual, and in some cases, if you send the patient to the same place to schedule both visits, it's going to help with engagement. Some other features to consider, since as telehealth remains part of our daily lives, is speaking their language and having the ability to connect and interpretive services with the virtual visit. So think about it as someone who is joining the patient maybe in the office, but this is virtually, who can actually speak their language and relay communication to the provider. Similarly, some patients prefer to have a guest join them in their in-person visit. So being able to add a guest virtually is also key. They can invite their caregiver or a family member, someone they trust. And then the last patient workflow I wanted to highlight is the ability to chat, screen, and document share. So to make the engagement of the virtual visit high, being able to interact not just via video, which is important, but allowing the patient to be able to chat, being able to share patient education or document with them as you're speaking with them, and being able to share your screen if you want to show some lab results. Similarly, telehealth features for providers also help with the provider engagement. We talked about how key ambulatory care thinks provider engagement is in terms of patient engagement success and IT adoption. So being able to capture an image. Video is great when you're interacting, but sometimes you need a closer visual of whatever that patient's talking about. So being able to have the patient take that image and send it as part of the virtual visit. On-demand scheduling. We talked about online scheduling, and that's very helpful for the patient to be able to go to one place for both. But sometimes a patient may call in, and it's really important for that provider to see that patient's face and demeanor or interact. And so being able to do an on-demand schedule, just turn that telephone call into a virtual visit is key. And then the other is the support user workflow. When you go to an in-office setting, there are a lot of other staff that help make the provider successful with that patient. So being able to have the medical assistant or even a registration or someone join the visit as part of that workflow is key to making that workflow successful. Okay, so now we're going to turn it over to topic 2, remote patient monitoring and ambulatory care. So one of the trends that has been getting a lot of attention is remote patient monitoring. So I wanted to broadly talk about how it's defined. It is defined by the patient using a medical device at home and regularly monitoring their condition or other measurement. Kind of going a little bit deeper, you see this illustration. So it can be the patient has an app that connects with those sensors. That data is processed and sent to the clinician in a real-time display. Examples of medical devices, blood pressure cuff, it could be a glucometer, it could be even a thermometer, as was very popular or needed during COVID times. Then there's an interaction, usually with the clinician and the patient. It can be in a live in-office visit, if a measure needs to be discussed or it's part of a normal follow-up. So there's a communication that could be virtual visits and email or even within the app. When we were looking at this space for our population, we wanted to test kind of what data. So we mentioned the different devices. We asked in a couple of focus groups, how would you prioritize the data you're interested in? And not surprisingly, some of the clinical familiar devices, blood pressure cuff, blood glucose, scale, weight, temperature, and pulse, were identified as important. Something that was a little bit interesting for us is some of the more wellness-focused items were also highlighted as interesting for our ambulatory care base. Exercise, nutrition, sleep data. Some of the challenges we identified with RPM from an ambulatory perspective are there are hundreds of devices and multiple categories. Patients may have a device. Providers want access to this data within their workflow without being overwhelmed. And EHRs are not designed to capture the type and frequency of the data available in the market. So if you think about taking your blood pressure once a day, 3 times a day, that is not the typical EHR workflow, or even providing your steps. I mean, there really isn't a great place in the EHR to capture your steps on a daily basis. I like to show this illustration because I think it shows some of the complexity related to remote patient monitoring. It's also showing just the volume of data that you can expect in RPM. And this is an example of a single patient who has 2 conditions. So it's blood glucose and blood pressure. So they have 2 different devices they're using for different purposes and the different frequency of when they take those. So this is an example of one of the screenshots from the solution that we're offering. The other thing, when we talk about trends with populations, we wanted to understand why are our clients interested in RPM? And this is what we learned in that same focus group I mentioned. They want to expand telehealth, gain more data insights, improve patient outcomes, and fulfill the obligations associated with awarded grant funds. There are some organizations that are out there helping to finance programs to help with health equity and to manage chronic conditions. You see some of the top physician practice responses on the right: provide a bigger real-time picture of data, improve patient engagement, expand telehealth. And so now I'm going to turn it over to Kim to do an introduction. Thank you, Kim, for joining. I'm excited that you're here.
Thanks, Cheryl. I'm excited to be here on behalf of Delaware Valley Community Health, our CEO and our board. I am going to turn my camera off for presentation so we can focus on the slides, just so that everyone is aware. I'm excited to share some of the great work that is done every day at Delaware Valley Community Health. The teams we have at our sites inspire me each day the way they care for our patients and communities. I will start to talk a little bit about myself, and then we can get into the organization on the following slides. I am a nurse that has been practicing for well over 20 years, and I've worked within the acute care, long-term care, and payer spaces, as well as forensics as a sexual assault examiner, and now at an FQHC. All of these roles have had one tenet in common for me: being patient-centric and empowered care delivered in a trusting environment or relationship. This really does apply to remote patient monitoring, telehealth, or connected healthcare, whatever name you want to give it. Because of my various backgrounds, I am quite comfortable with care outside of the clinic walls. Because I believe at my core, the care doesn't have to happen in the clinic setting. Healthcare does move at the speed of trust. COVID has pushed the ambulatory community to think about this more globally, and that was the case at Delaware Valley Community Health. Delaware Valley Community Health has 8 locations. We are opening and finished opening our 9th site as well this fall. We have services that range from adult medicine, optometry, behavioral health, pediatrics, women's health, OBGYN, podiatry, dental, and medication-assisted treatment. Our mission has centered on, for more than 50 years, that we, Delaware Valley Community Health, deliver affordable, accessible care to the uninsured and underinsured patients. In my time with this organization, I've worked with thought leaders at all levels of our company: our Chief Information Officer, our Chief Medical Officer, and our Chief Operations Officers are key partners in aligning our care delivery goals across all of our geographically dispersed sites through Philadelphia, Delaware, and Montgomery counties. To provide additional background before we jump into remote patient monitoring and our work, I do want to talk about the use of virtual visits at our organization early in the pandemic. When DVCH had to pivot quickly in the early stages, we used telehealth to stay connected to our patients, particularly those with severe conditions or acute needs. We needed a virtual visit tool that was equitable for our entire community to continue continuity of care and that was familiar for our care teams, something that would onboard efficiency and maintain accessibility for our patients. This information related to our virtual visits for well over a year will tie into my discussion for remote patient monitoring. So how did the journey start? As you can see, the Department of Health and Human Services awarded DVCH a grant that will cycle for the next 3 years. Through this initiative, HRSA awarded funding to health centers receiving Health Center Program Operational Grant, or H80 funding, that met specific hypertension criteria. We had to have achieved blood pressure control in less than 58% of our patients. This is age 18 to 85. Served at least 100 patients, 18 to 85, which we met extensively. And the award recipients will use the funds and other available resources to conduct outreach and engage patients with uncontrolled hypertension to participate in this initiative. To ensure access and support the use of Bluetooth and wireless-enabled self-monitor blood pressure devices for most of our patients with hypertension, we needed a strong partner to be able to collect and share this data and to be able to meet the requirements for the grant. DVCH worked with 2 vendors, but have decided to move forward fully with the RPM tool from NextGen, since this will integrate easier into our EHR. We had begun some of our work prior to the HRSA grant, so this allowed for our org to hit the ground running with key partners like NextGen. We really wanted a tool for remote patient monitoring that facilitated patient care, not the driver of patient care, and most importantly, not a barrier to care. With the NextGen RPM tool, we have been able to honor these tenets, not only with our patients, but also with our care teams. On this slide, I'm just going to go through some of the options of the RPM system and how DVCH is using them. Many of the features are malleable and allow for refinement based on the ambulatory site needs, staffing, patient volume, or your outreach plan. Keep in mind that as I review how we are using it, this does not mean how you would use it or could use it. This also doesn't mean how DVCH will use it for the remaining 2 years of the grant. We are continuing to evolve each day. There is an in-app enrollment, which makes it easy for patients to enroll. DVCH does this side by side with our patients, with our care team and patients looking at the same screen together. At DVCH, we have partnered with our care coordination team members to directly enroll our patients. Real-time display views and tracks device data. This helps our care coordination team see the same data the patient sees and makes troubleshooting much easier. We do have goal management available. This enables the patients to view goals set by the care team with their providers. At DVCH, we set our goals just to take the blood pressure twice a day. We wanted this to be easy for the patient and not to overcomplicate it. Now that I have covered the what and the how, I'll be sharing briefly some of the tools we've used to support our choices in design of this program and how we've implemented it. Like I had said before, DVCH, or Delaware Valley Community Health, is an FQHC that routinely reports data on our quality indicators, often to the federal government, HRSA, as well as payer organizations, and NCQA for accreditation. We are also used to working within learning collaboratives and sharing tools, workflows, or best practices. I know some of the listeners do not have this infrastructure or support. So I've listed on the slide items to consider as you explore an RPM program related to hypertension. Using validated tools, like the AMA Hypertension SMBP Quick Guide, is a great starting point. This was the basics for our preliminary exploration and design work. Using a validated device and doing that research is key. The listing at the validatebp.org, this will give you a starting point as well to look at cuff features, cuff sizes, and who has validated the cuff. It's a nice starting point to review with your team before purchases are made or recommendations are presented for budgeting. Lastly, I have listed the recognition program. Having a goal for the project really gets everyone moving in the same direction. For us, we report this data yearly to HRSA, and the target BP recognition could also be something that a smaller non-FQHC could explore to help with benchmarking or a measurement framework. Now that we've talked through some of this content, I do want to move to some best practices as you think about how to use devices and build for your team. These are some early learning tidbits. This is in no way, let me say again, no way a full list, and it continues to evolve to this day. But this will give you some items to think about as you entertain the idea of what remote patient monitoring would look like for your organization, practice, or care team. The first one is know your patient population. How many patients do you want to tackle? Make sure you have baseline data to be able to measure improvement or benchmark. For DVCH, it's our yearly reported HRSA data that is related to a hypertension or BP control. We also looked at technology needs for our population. Because we had ventured into telehealth, this gave us some preliminary information to know we would have an option. We would have to have an option for a smartphone to be free, to be able to make sure some of our patients who didn't have access to smartphones would still be able to be included in this program. Back to the thought I mentioned earlier, as we integrate more and more technology, we at DVCH wanted to be really intentional about looking at barriers and having that mitigation plan. We have a phone program that does allow for those who do not have a smartphone to still participate at no cost. By looking at factors like SCOH or those social influencers of health, as well as seeing the 7-day data from home, much different than in-clinic values, and we start to see possible factors that are really interesting. One of our nurses noticed that a patient had a different BP value when he had a stressful event than when he didn't, and this was related to a dental visit for this patient. A lot of times he would schedule the appointment to come in and then also see our dentist right afterwards. These are the nuances that can really be seen and explored with RPM, looking more towards that precision medicine model that uses data and population health analytics to really produce these targeted therapies. I accidentally advanced the slide forward. I'm going to go back, sorry. Create the right team. As you can see, I have an S there on the slide. It's not just one team. You really need leadership buy-in, advisory teams, as well as implementation teams. For me, I've been extremely lucky that my implementation team, led by Janine Gibbons and Sarah Quick, was able to mobilize our frontline staff as we rolled through one site at a time. This implementation team also helped us refine the process, as we still do to this day. This morning, we were making some changes. We continue to put this project through Kaizen-like review, as well as PDSA type of workflows. Our various advisory teams use two key project managers, Maddie Kemeny and Evie Cologne. Yes, it may seem like we have this robust internal team, and smaller practices, this may be frustrating, but you really have to think about this infrastructure or who's going to do it. This is part of that goal setting. I understand that, and I remind you, I do have a grant, a timeline, and also plan to implement this across 3 large sites to eventually touch over 4,000 patients as part of the grant. We really needed teams plural. We are also now having our student nurses that come to our sites work with our site nurses to expand our enrollment team. These teams keep growing. Lastly, think about designing the right workflow. This took a lot of planning in the beginning. This was something we worked on in advance of receiving our grant. As an FQHC, we can connect with our Health Center Control Network, or HCCNs. DVCH was able to work in advance of this HRSA grant with the Health Federation of Philadelphia, our HCCN. That also allows us to share these wins, missteps, and recalibrations with other FQHCs that are on the same journey. I share this because if this is a new venture for you, delivering care outside of the clinic walls, lean on others who have started. It also speaks to consistent underlying tenet that primary care, as well as quality management and new innovations or ventures, these should all be a team sport with a really integrated workflow. An example of having the right team member as part of the interdisciplinary team is how we used our pharmacist, Megan Nakla, who has been able to review our patient progress, make recommendations to our providers about med changes that can be moving from a 2-pill regimen to a combo medication to drive up adherence. She has also noted cost savings based on medication choices, what plan or insurance the patient has while enrolled in the program. A downstream impact to this work is that our value-based contracting metric will continue to reap these benefits of med adherence as well, since the patient's adherence will go up. As I close out my slides, I leave you with this thought. Some leaders have been quoted as COVID-19 is or will be a catalyst. I was one of those that posted on LinkedIn early. I have now come to realize, especially in healthcare, COVID-19 has really become a magnifying glass. It has really intensified areas that need work, as well as things that are working well. For me, I wanted to design a program that distributed equitably across our patient population, that was digitally enabled, and worked with our EHR to allow for decentralization of our care teams. So far, we've been able to accomplish these tasks, and our teams continue to refine delivery of care each day. I look forward to hearing your questions towards the end. At this point, I'm going to turn it over to one of my other partners from NextGen to discuss interoperability.
All right. Thank you so much, Kim. Really great to see how Delaware Valley, implemented all these awesome solutions and really partnered with us and with your patients, right, to deliver on these cool outcomes. So for this section, talking about interoperability, organizations, and to Kim's point about COVID really being a magnifying glass, I hope and I think that what's happened during this pandemic is organizations have found a greater need to be able to exchange data outside of their 4 walls. And the way we do that today is with interoperability. we have a ton of data exchange solutions out in the market that are actively moving clinical content at scale. And in a what we're also finding is that this is now becoming much more automated, and rules-driven exchange is happening. And so I want to walk through a little bit of the interoperability landscape as it exists today, highlight some of the challenges that organizations are seeing, and then potentially talk about some available solutions. So across the space today, stakeholders really have a number of key challenges. Organizations of all sizes, all types, are really grappling with a number of really common themes. Patient identity being, a top-of-mind concern. Top-of-mind concerns, for example, the ability to share data about an individual patient based on activity that's happening inside the clinic. I'm going to walk through a handful of these, and you may find some that are relevant for your organization, some that are maybe solved by integrations that you have, or others that are still open questions. Number one on this list, at least in my estimation, is organizations that activate data exchange services really are challenged by time to value. Turning on a new service, proving to the organization, proving to your patients, to yourself, that activating a new service is going to deliver immediate value has been a challenge. For organizations, healthcare delivery organizations that are growing, often turning on a new practice or acquiring a new practice, getting the benefit of that data from the acquired practice is a challenge. And this is really, tied into number two on this list, which is data assets are growing, but we still have data silos. So organizations who have, let's say, in that growth mode, acquired a new practice often find that the data from that practice is still locked in a legacy EHR. Tools that enable the data exchange may, for example, alert you on transitions of care or encounter notifications, but the full view of the clinical record may often still be locked behind an interoperability solution that is just not working. Some of the challenges on this screen may be alleviated or remediated by an EHR's built-in integrations, like a connectivity to a national network, for example. But other solutions often require, deep planning and really a partnership with your integration vendor or your EHR company to provide a solution that works. So one-off integrations are not always a substitute for the level of exchange that is required. Legacy solutions like a plug-and-play HL7 interface may not meet the needs if what you really need is a longitudinal view of the patient's clinical record. So across the space that we have in healthcare today, we have some really positive activity around interop, but there still are a number of legacy challenges. And I don't think there's a silver bullet anymore. There are no more big bang solutions that are available. We now have more than 15, 20 years of healthcare data in systems, and solutions that are proposed, solutions that are implemented, also have to acknowledge and integrate and interoperate with the legacy solutions that are in place. And this is a really important idea as we move forward. One thing that gives me real hope, though, is that we now have a standard definition of interoperability in a way that we have not had in the past. And regulations have actually, I think, driven the industry to solve some of these key challenges in new and interesting ways. The definition that's now available for interop has been put into regulation through the 21st Century Cures Act. And it really describes three important aspects of interoperability: that it is the exchange of clinical information without special effort. That term, without special effort, really is doing a lot of work in this sentence. And hopefully, when this comes to pass in our industry, what it means is that participants, this includes providers, payers, labs, radiology systems, but most importantly, patients who participate should be able to access their data without any special effort, that it's just available to them. And this phrase is really important. But then building on to that, number two, as part of the definition, is that it should encompass the complete access. So I should be able to access my data without special effort, and what I access should be everything. Every possible bit of information about a patient's record should be available for exchange. And there's also the part of this number 2, which is and the use of that data. So it has to be available in a format that is usable by the patient, by the provider, by the system, and so on. And then finally, number 3 on this list, very importantly, and kind of a new concept for us in the interop space, is that it should not constitute information blocking, right? So it should not be a practice or a procedure or a technology that limits or prevents the sharing of data. Now, there are a number of provisions that really, allow an organization to limit the exchange of data in a number of really key areas. So there are some provisions, but it changes really the policy position, where if you remember with HIPAA and high tech, the idea was that, the default position was not to share, right? To prevent the sharing of data, to protect the patient's privacy. And privacy implications are still absolutely intact. Patients have the ability to decide where they consent to share, not consent to share. But the new default position with 21st Century Cures is the sharing of data is the default position, unless a handful of provisions are met, where you don't have to share if it's an encumbrance or expensive or so on. But this is really an important aspect, and especially for those of us who are patients, which we're all patients at one point or another in our lives, it means that we will now have immediate and real-time access to our own clinical records, which is really exciting. And for technology vendors, we have to be able to meet the rules, the spirit of the rules, but also the technical requirements of those rules in all of our products. And here at NextGen, we think about interoperability, and we deliver interoperability solutions across 4 broad areas. Transactional data exchange solutions, things like orders and results, and prescription drug monitoring program interactions, and immunization registry submissions and query of data from immunization registries. We also have data aggregation solutions that allow an organization to build a longitudinal record across an entire community of disparate and different EHR systems. And then all of our tools have to be, thinking back to the information blocking rule and 21st Century Cures, all of our tools have to be accessible now with APIs. So the solutions that we build, including the EHR and the PM system, have to be fully interoperable with the latest data exchange standards that are now delivered through secure APIs. The same types of tools that connect, our mobile phones and our smart home devices, those APIs are now in healthcare as well. And as vendors, we have a responsibility to deliver robust and rich APIs. And then finally, national interoperability solutions. Across the country today, there are a number of key networks that enable secure data exchange in support of all of the things that we talked about earlier that Kim and Cheryl educated us on. Those same technologies that enable the remote patient monitoring, an extension of that technology can also enable exchange of data with other organizations in the community or around the country. So there are really 4 key things that I want to describe here with interoperability specifically. 4 things that I believe are really important and good for all time zones, wherever you might be across the country. Likely one of these solutions is going to be very meaningful to facilitate your data exchange. Number 1 is connectivity with a local or regional health information exchange. So across the country today, there are more than 70 accredited health information exchanges that are part of what's known as the Civitas Networks for Health, what used to be called the SHIC membership, the Strategic Health Information Exchange Collaborative, now is called Civitas. And there are more than 70 of these HIEs across the country that are often nonprofit public utilities facilitating data exchange. And what they allow is an organization to submit data to the HIE and then later on for other organizations to also contribute a copy of the patient's record to the HIE, and for the entire community to be able to query and retrieve data about the same patient. So HIEs facilitate patient identity, they facilitate the document exchange, and they enable everyone in the community, in the region, to access the clinical information. And when I said that HIEs are really becoming a utility, what we mean is that they've organized themselves such that they serve the community. So different HIEs have different focuses on services. Some HIEs have really connected all the social services in their community, whether it's housing or veteran connectivity. Meals and meal delivery services are now being orchestrated through the HIEs themselves. So if you're in a region where you have a robust HIE, I highly encourage you to connect if you're not already connected. Two others that I'll chat about really briefly here. Number one, direct messaging. Across the country today, one of the primary ways that organizations find out when a patient has been admitted to a hospital or discharged from a hospital is through the use of secure email direct messaging integrated inside the EHR that allows a hospital or health system to notify providers in the community that a patient was admitted or discharged, or if you're a specialist, you can use direct messaging to receive referrals from primary care physicians and other organizations in your neighborhood. Direct messaging works today with every certified EHR. And as part of Medicare's interoperability and patient access rule, hospitals now are required to send admission, discharge, and transfer notifications to all of the providers in the neighborhood who may have privileges at that hospital. And the primary way that organizations like hospitals are achieving that ADT notification rule is through direct messaging. And so if you haven't already activated direct messaging, not just activated, but really optimized it, right? Set up and configured rules to route messages to the provider's inbox or away from the provider's inbox. That's often one of the most important things an organization can do, is set up rules to minimize the number of messages that hit a provider's work queue, because we know directly that contributes to a ton of burnout in our space. So direct messaging and direct messaging optimization is a really critical step that organizations need to take. And then finally, the last key service, good again for all time zones, is Carequality. And this Carequality network that enables a query and retrieval of data from one provider to another allows organizations to discover where a patient has been treated. And then once you know where a patient has been treated through the Surescripts record locator, for example, you can actually get a copy of that patient's record without waiting for someone to approve it, without waiting for someone to click a button and say, yes, you can have a copy of the record. So long as you're making that request for the purpose of treatment, and there are other use cases that are now being supported, treatment, payment, operations, and public health as well. As long as you're making the request for an approved use case, you can immediately get a copy of the record. And likewise, if you're on a connected system, you can make your data available to trusted participants on the network. So these three things that we talked about, HIE connectivity, direct messaging, and Carequality, are ways that you can expand beyond the four walls of your organization, find out where your patients have been treated, and retrieve a copy of their record or receive it from external providers. Nowadays, most of this content, like the CCD, is fully reconcilable, right? So the meds and allergies and problems and things like family history and social history, all of that content can now be incorporated into a patient's chart very seamlessly. So for new patients who are coming in, you can be ready with actionable content in the patient's record before the visit even starts. And more, patients expect that providers will have a copy of their record from other organizations in the community, right? And as patients, we also can all demand that and request that of our providers if they haven't already implemented it. So those are the things that I thought from an interop perspective were really important to mention, and I hope those three, HIE, direct messaging, and Carequality, are items that if you're not already implementing, you can talk to your solution provider or talk to us to find out more. So with that, I think we will kick it back to a Q&A and hopefully take some of your exciting questions. Thank you very much.
Wonderful. Thank you all for that presentation. We are coming up on time here, so I'm going to move us to the Q&A real quick. So Cheryl, this one's for you. How does the data from the patient RPM device get into NG in the format you just displayed? And is this different for every device?
Thank you for your question. And we didn't want it to be different for every device from the patient's perspective. So the way the data gets into the display that we have on our virtual visit platform is it connects to a mobile device. So in the example that I gave from the display, that had a glucometer and a blood pressure device. So one mobile app for the patient that they would take both of their devices and measures, and it would show up in their device. And then that data would be sent to the NextGen display on our virtual visit platform. The way the data looks is specific to the device. So we kind of showed a little bit of difference of what a glucose reading would look like versus blood pressure versus temperature. So the data types are different. And how it's displayed also is based on the goal set for that patient. And Kim mentioned a couple of examples of that. If you're asking your patient to take their blood pressure 3 times a day, now you have a different set of data points than if it's 1 time a day. And if it's their glucose readings 2 times a day, 1 time a day, morning, afternoon, and even things such as alerts if it's out of range. So we've partnered with a company called Validic, and our remote patient monitoring program leverages the Validic impact, and we've incorporated it in our virtual visit platform. The other piece I wanted to address about workflow, because we wanted to walk before we ran, we are having the clinicians decide what kind of data gets sent into the EHR. So all the data is available on the display. They are able to pick and choose what they want to go into the encounter in the EHR. Great question.
Thank you. How is your remote patient monitoring solution managing medications from inside the home and capturing data in order to decide on interventions and improve outcomes?
I'll take that one because I think it refers to my mention about our pharmacist. She's part of our interdisciplinary team. So what's happening is our EHR through NextGen shows the medication module, and our care team sees all of that information because we're all in the EHR. And with the remote patient monitoring, the patient is able to take the blood pressure, and we get that 7-day average, and we are able to make decisions based on the care team interviewing the patient. Maybe there's an adherence issue, maybe there's a cost issue, but they also take that clinical data, the pharmacist and the provider, and have that decision made as to whether they're going to titrate or change medications. So it's not something that comes necessarily through the platform. It is something that is already in our EHR that we're using to augment the data coming in on the 7-day SMBP average.
Thank you. And Kim, we'll stay with you for the last question. What's next for your hypertension RPM program?
Like Cheryl mentioned, we too are walking before we're running. We are really just trying to evolve and change as we see needs. We currently are getting to the point where we have a robust caseload that our care teams are monitoring, and we're trying to make sure that we're managing that and having our care teams work to the top of their license and minimizing, as Cheryl said, the noise that we want to either stay in the portal before it comes into the EHR. So right now we are in that refinement stage and continuing changing and evolving, and then we will start running next year in our second year of our grant.
Wonderful. Thank you. And Cheryl, I'll hand it back to you.
Great. So we just wanted to provide a summary. So let's go back to the beginning for a moment. We kind of highlighted that telehealth has evolved drastically over the last 6 to 8 months. What's considered to be possible outside of the clinic walls has rapidly expanded. Virtual care is going to remain a must-have. and it will become a larger piece of care given to patients as trends like remote patient monitoring become more standard. Interoperability services can help empower you with knowledge about patient activity outside of your four walls. So our final thought for you is now's the time to plan how you're going to operationalize virtual care in your practice, implement it so you're ready for the market demand of the future. Thanks for joining our session.
Wonderful. Thank you all for attending this session. We hope you found it insightful and educational. Please note we have a couple more sessions to go within the Connected Health Virtual Summit. If you're interested in attending any of these upcoming sessions, click register for upcoming sessions under the resource list. That concludes this Connected Health Virtual Summit session. Again, special thanks to our speakers, Kim, Mo, and Cheryl, our audience, and our sponsor, NextGen. From the team at the Connected Health Virtual Summit and Extelligent Healthcare Media, thank you all and goodbye.